Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
So I welcome one and all for this very, very important and conceptual class today. The thing about today's class is that I'm going to be discussing CTG, and this is not in connection with the CTG that you must be knowing before. This is a new category of CTG which has been recently announced by the NICE guidelines. As you can see over there, it's written. The guidelines are published recently in December 22, and it's a very high chance that this is going to be asked in your examinations along with OSCE. So this is a very important, and otherwise also, so you should know the importance of CTG and what you're going to do if any of these conditions they do arise when I'm going to be discussing with you in the class. The other very important thing about CTG is that the previous CTG guidelines to the current CTG guidelines, you should know the difference between them. And if you do know, the earlier way, of classifying as reassuring, non-reassuring, and abnormal. Okay, reassuring, non-reassuring, abnormal. These were the features you used to find. First of all, that conceptual thing should be there in your mind. These were the features you used to find in the CTG. Okay, that the CTG is well, it was normal. CTG is reassuring, or CTG is abnormal. Okay, so it's reassuring, non-reassuring, and abnormal. Okay, and then you categorized it into the category of CTG. That means whether it's a normal CTG, it's a suspicious CTG, or it's a pathological CTG. So normal, suspicious, and pathological, they still do remain. The categories, they still do remain. But these, terminology of the features of the CTG, they have been replaced by now white, amber, and red by the latest NICE guidelines. And with this concept, we move forward in today's class. So first of all, we perform an initial, very important in the labor room is to understand whether this patient needs continuous CTG management or this patient needs just intermittent auscultation, right? So if she's a young primary gravida with no high risk factors, she can be put on intermittent auscultation during the first and second stage of labor, right? But if she's a high risk candidate, maybe an IVF conceived pregnancy, or an elderly primary gravida, or a patient with one of the many confounding factors like preeclampsia, severe preeclampsia, IUGR, and I'll be discussing, the list is there to come. This is for the obstetrician to kind of understand whether this patient needs continuous assessment or she needs just intermittent auscultation. And before we move further, please quickly write down in the chat box whether you can hear my voice properly and you can see the screen properly. Quickly, guys, because we need to discuss a lot about CTG, and I need to know whether we have this, whether you can see everything and you can also hear my voice properly. So, all right, okay. And with this, you'll also be able to understand how to reach my Telegram, right? So I just request you all to just quickly write down in the chat whether you can hear my voice. Okay, thank you so much. Thank you so much, guys. Move forward. And you can see the screen also, I hope, right? Moving forward. So this is just a quick initial assessment of every patient wheeled in your labor room you need to do to assess what? The antenatal risk factors for any kind of fetal compromise because of any maternal condition or fetal condition, to understand whether this patient needs intense monitoring or she can easily be dealt with intermittent auscultation. And what are those guidelines? Even for that, we have a few important things in the guidelines. So indications for continuous CTG monitoring. See, this is, just look at this, okay? This is one slide, 2, 3, 4, 5, almost 5 slides are there, and how much I'm going to remember. So I've just made a very fundamental understanding for this, that any condition that you've read so far, high risk obstetrics, you all know. So any condition which causes a fetal compromise, in the sense that fetus can go in distress for this patient, that condition is going to be taken into account as a condition which will prompt you for continuous CTG monitoring in labor. Okay, so amongst which I'll quickly just read through and you'll be able to understand it yourself. See, previous cesarean birth or any full thickness uterine scar. What are we scared of over here? We are scared of uterine rupture and sudden, fetal distress. So, see, we are concerned about uterine dehiscence, uterine rupture. And uterine rupture and uterine dehiscence, how will it reflect? It will reflect by fetal distress, which will be seen in CTG. The first thing which we can pick up over here is the least amount of fetal distress, and that prompts us into thinking whether patient is doing all right or there is actually a scar dehiscence. So anything which will reach to the fetus, right, in any which way is going to cause a fetal compromise, like a previous cesarean birth, any hypertensive disorders, okay, because that causes usually placental insufficiency, deranged Doppler flows, fetal distress at very early labor, okay. Prolonged rupture of membranes, we are not concerned if the patient is gone into labor herself, okay. But if the patient has been admitted, there has been a prolonged time delay from the rupture of membranes to the onset of labor, she's not yet into labor, and you induced labor, and then you are monitoring her, well, this is a patient who has a very high chance of developing chorioamnionitis, which will reflect on the fetus. Any vaginal blood loss, which is very obvious. Suspected chorioamnitis, I already told you. Pre-existing diabetes, because diabetic females have respiratory distress syndrome in their babies, okay, and that will reflect as a fetal distress. So all those conditions that you know already in high risk obstetrics, just remember those chapters that you've read, and every chapter will automatically make a condition for you. Okay, so diabetes mellitus, hypertension uncontrolled, IUG is also going to come very soon, chorioamnionitis, all these things are risk factors and one of the indications for continuous CTG monitoring. Offer continuous CTG monitoring for women in labor who have any of the following, especially non-cephalic presentations, because such presentations usually they are responsible for either cord prolapse or placental we call it the pull or the push on the placenta, okay. The head is like pushing on the placenta, especially at the time of the second stage of labor. Anyways, that remember non-cephalic presentations, fetal growth restriction, like I told you, even small for gestational age babies, they seem to have some amount of compromise, especially during labor. Polyhydramnios, especially oligohydramnios, not anhydramnios, but definitely oligohydramnios. Okay, reduced fetal movements, which are already there at the start of all these are high risk statements, right? Contractions. Now we come to very important new intrapartum risk factors, which are in which you can offer continuous CTG. Right now we're just talking about those conditions in which you can offer continuous CTG monitoring, right? So contractions which last longer than 2 minutes, or there are more than 5 contractions in 10 minutes, if there is already a presence of meconium in early phase of labor, the patient is having maternal pyrexia, the patient is having pyrexia, fever, suspected chorioamnionitis or suspected sepsis, okay, and any kind of pain which was not the kind of pain she experienced in the previous labor, okay. So you're already thinking of protracted labor or Bandel's ring or whatever, this happened with me as well. In the labor room, there was a patient who was already a third gravid and she was shouting like, as if this is the first time she's having labor, very, very, and I was a resident at that time, and my consultant, she came into the labor room and she was drawn towards the place where I had taken her inside. And she was seeing me, very nervous with the patient. She asked me, what happened? I said, she's just shouting as if, it's not even the, first time. She's a new beginner for, all these things. And the way she's behaving is very strange. So she said, what? She examined her a little bit and then she said, I'll take her up for C-section. Immediately, the decision was taken. The relatives were called. They said, yes, okay. And she finally delivered. And later on, my consultant told me that maybe it was early start of Bandel's ring formation or some protracted course of labor, which we cannot pinpoint to, but it is always good practice to let your concerned authority or obstetrician know what is the condition of the patient, and she's behaving in any which erratically. So the labor was going smooth, she was dilating absolutely fine, fetal heart was also all right, but the way she was shouting was far more exaggerated than even a normal primary gravidas would shout in the first stage of labor. So that was the thing which prompted her to take this step. So even any pain which is much more than the pain usually that is seen in the different kind of pain, or she's behaving very different from it was the scene before.